Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The slide deck will also be made available on the class website under the Education tab. Stephanie will post a link in the chat with a short questionnaire asking for seminar topics and speaker suggestions. Following the presentation, we'll also have a Q&A. And then just as a reminder, we have another presentation on December 5th with Dr. Julia Adler-Milstein from UCSF. And so Dr. Borsky and Dr. Harrison sent us their bios, but rather than kind of running through that, I know that we ate up some time with the technical difficulties. I just want to say that I met Michael at the D&I conference, Dissemination and Implementation Science conference last year. We were both attending a Learning Health Systems seminar at the conference, and that's where we met and we connected, and I thought that he would be a great speaker for our seminar today. So invited him along with his colleague, Dr. Amanda Borsky. So I will pass it to them to sort of introduce themselves and their topic that they're going to be talking about today. So take it away, Dr. Borsky and Harrison.
So thanks very much, and apologies to everybody for the delays. We're delighted to be with you. The topic, as you can see, concerns the role of funding, particularly external funding for our learning health system research. I recently retired after 20 years of service at ARC, and prior to that was a university prof for several decades. And Amanda was a colleague of mine at ARC and has now moved over to the VA. So both of us are no longer at the agency where this research was conducted. Needless to say, these are our own interpretations and findings. They don't reflect the views of the Agency for Healthcare Research and Quality, the VHA, or any other government agency. Can you move the slide forward, please? So we want to just start with a couple of polling questions, and I think given the time constraint, we may just want to even just do the first two. Do you have a full or a part-time appointment in a health delivery system? Please let us know, yes or no. And if yes, are you expected to contribute directly to internal system improvements? Those two items will give us some idea of not only how many people are on the call, but also how engaged they are in the kind of work that we're talking about directly. And we're going to have a lot of opportunity at the end of the a presentation for your comments, so we'll hear more from you at that time. Okay, well, give us some idea here. We've got a substantial number of people with appointments in delivery systems, and of those folks, the majority, almost all, have some kind of expectation of contributing directly to internal system improvement. We see 8 out of the original 9. So that gives us a clear idea that we're on the same page. Can you just advance to the next slide, please, Andy? So this is our plan of action for the presentation. Amanda's going to talk about the study design and analysis and begin the discussion of findings, particularly talking about some of the benefits and limitations that we observed of reliance on external competitive funding, and then moving into discussion of strategies that we actually observed that make external funding more useful for health system improvement and help overcome some of the constraints and challenges associated with it. And I'll pitch in to that discussion and then also lead discussion where we really want to hear from you about how you can support the objectives of the learning health system and align your work with its processes while at the same time advancing science and your own careers. So at this point, I'm going to hand it over to Amanda. Amanda, take it away, please.
Great. Thank you, Michael. And just really thanks to everyone. Really excited to be here with you all today and excited to get into the discussion. But first, want to give you a little bit of an overview. Let's go to the next slide. So here's the 2 main research questions that Michael and I sought to answer. First was, what were the challenges that relying on external research funding posed for learning health system programs? And the second is, what were some strategies that helped the learning health system research programs reduce the gaps between relying on the external funding, and contributing to health system improvement. Next slide. And so I think also important to our research questions is, what do we mean by learning health system research or embedded research? And actually, as we were working through the technical difficulties, this came up. There's lots of different words for the same thing, and everyone has slightly different definitions. So here's how we operationalize this. We defined learning health system or embedded research as research that was done within a health system that first involved systematic investigation by the researchers who were employed by the healthcare system or invited to conduct research within it. They had to be examining care delivery or conditions affecting it, and not just purely clinical topics. And 3 is the research had to mainly or primarily contribute to improvement in the system performance, and only secondarily to enhancing scientific knowledge. Next slide. So to do this, we used a case study design. We had 5 sites. 4 were academic medical centers. 1 was quasi-academic medical center. We conducted 38 interviews with folks at various levels within the learning health system, including the leadership of the learning health systems themselves, the directors of the research or learning health system programs, and the researchers. And we identified these individuals through snowball sampling. So when we talked with one person, we explained the types of individuals we wanted to talk to within the system and had them suggest other individuals to talk with. To help inform our site selection, we had originally conducted 12 interviews with learning health system experts to understand the broader field, context, and help narrow down our site selection. And we also looked at the published and gray literature. And we also, in our 5 sites, we intentionally did not include the Veterans Health Administration. As Michael said, that's where I am now. But while we did this work, we were both at ARC. And the reason why we didn't include the VHA was different. And I will confirm after now being there, it really is and was a very wise choice. VHA is intramural research funded. So to get funding from VA within the health system, you have to be part of the health system. So it was very different, still very robust, but just wouldn't have given us as generalizable or externally applicable findings. So VHA is excluded. Next slide. So in terms of our analysis, we use the rapid qualitative analysis, which is similar to thematic analysis, but a little bit more applied of a method that is often used actually within many health systems as well. We use an iterative approach where we took our transcripts, we then summarized iteratively. So we summarized first within the health system after we talked with all the interview respondents, and then we summarized across health systems, which led us to the analytic summaries. And this iterative approach really helped us to start to see findings and themes both within and across as we conducted the interviews across the health systems. And then once we had our interviews, all summaries, we tried to summarize and use inductive to look at the benefits and challenges of external funding for the researchers and the systems. And then similarly, I inductively identify some of the strategies for how to handle and the challenges faced with external funding. Next slide. All right, so here's our 5 sites. And I wanted to spend a little bit of time to give you a sense of what our 5 sites are. As you can see, they vary in size as well as leadership, both some clinical MD leadership, some more research PhD leadership. They also vary in their funding source. 2 out of the 5 are mainly externally funded. 2 are mainly internal, and 1 has a mix of both internal and external. And you can see their expertise varies. And as you'll hear from some of our findings, I think some of the expertise also is correlated with the internal versus external funding source. So just to give you a sense of the 5 sites, let's go to walk through the first site. This was an applied unit within a Health Systems Innovation Institute. It was started in 2010. The leader was a PhD, and they had approximately 30 FTEs. It was primarily externally funded. Some of the areas of focus in terms of the expertise included primarily human factors, health information technology, quality, and safety. Our second site was an independent center in an academic medical center that was started also in 2010. And this one was co-led by both an MD and a PhD. It was larger, had about 80 learning health systems researchers, both internal and external funding, and they did a lot with operational quality improvement research as well, which often then could sometimes lead into the externally funded research. Their areas of focus included improving clinical outcomes, safety, patient experience, access, quality improvement, data, and analytics. Our third site was very small. There were 2 part-time leads with some staff and a fellow support. This started in 2016, and this was also co-led by an MD and PhD, and most of its funding was externally funded. One of the main areas of focus of this group was implementation science. Site 4 was a learning health system division within a research center that started in 2011. It was research PhD led with approximately 20 staff. This one mainly had internal funding. Some of the areas of expertise included healthcare engineering, knowledge synthesis, quality synthesis, and affordability. And last, our 5th site was an LHS-focused program within a research center that had 3 co-leads, folks with expertise as an MD, MPH, MHA, where there were 8 core members, and then 65 researchers that they could pull upon for the learning health system research. This was mainly internally funded, and some of the areas of focus included evidence reviews, implementation design, and practice facilitation.
Amanda, just a note before you continue, just for the record, we did look at a 6th health system, but it's not a part of this analysis because it really was not an academic medical system. It was a community-oriented system with very little external funding, so it really wasn't appropriate for this part of the discussion.
Absolutely. No, good point. All right, next slide. All right, so what did we see as some of the benefits of external funding? First was external funding could help improve care delivery. There was an example we had where one site had a project with community resource workers that were helping primary care clinics address social determinants of health. So it could lead to internal care delivery improvements. It also helped, getting external funding helped have rigorous and multi-site research where you could expand a pilot of nursing home visitation from one of our sites and make it bigger given the broader funding base. We also saw where some sites use external funding to take what was originally an internal QI project and develop it into a much broader opportunities through learning networks with that external funding. We also had some sites that really talked about how having the external funding helped enhance their system reputation, and also help them as a result actually recruit really amazing staff and advance those staff as being leaders and experts within the field. Next slide. But there were also challenges to getting external funding. I think one of the first themes we saw was the different goals and incentives, where we heard from many leaders. They were concerned with financial standing, their star ratings, leapfrog, not as much about the research. They also had different metrics about what they were looking at and how they measured success that may be different from the research audience. Researchers and many of these sites were really focused on their grant funding and scientific achievement and external visibility. And again, very different goals from the health system leaders. The timetables and the processes were very different. Internal leaders, health system leaders, they needed answers in weeks or maybe months. But for most researchers, that's just not feasible. Getting a project just started can take it much more than that. So while the researchers were using very rigorous designs and methodologies that would lead very robust results, it was going to take a lot of time that the health system leaders just didn't have available. Some of the other gaps were in some of the sites that were primarily focusing on external funding. The researchers often had limited clinical knowledge and therefore kind of limited understanding of what issues the health system leaders were facing in terms of providing care and how that research could then be used for care improvements. Again, that relates to kind of the point about not really understanding the operational needs, concerns, and constraints from the health system, which is important for trying to make sure that the research can be used and applied. And we found that some researchers in health systems, if they're mainly externally funded, they're not familiar with the operational needs, they may not have much contact with these health system leaders. They may be in very different departments. They aren't part of the same meetings. They aren't part of other efforts where they can share and learn from one another. Next slide. I think here just a couple points to point out is that, at sites where you had it mainly externally funded for the researchers, Often that meant there was limited support for implementation or sustainment beyond the study. So the study was conducted by the researchers. Let's say they had really robust, rigorous design, very important findings that led to care improvements. They weren't connected with the health system leaders. How that research could actually be sustained and continued was often quite limited. We also saw, when I went through the table about each of the 5 sites, that sometimes there's a mismatch of skills and expertise. Whereas the health system leaders may really want help with things like workflow design, modifying the EHR, how to do practice facilitation, as not as much on rigorous study design methodology that your typical researchers often have. Next slide. So just to illustrate a couple of the challenges in terms of quotes, because as with any good qualitative research, this really helps tell the story. So in terms of the difference in the goals and incentives, the first one we have here, the hospital leaders were not as concerned about the research element. I think they get hung up, and rightly so, where everyone's worried about what their CMS star rating or score might be, leapfrog or one score or another. And this was noted by a clinician. In terms of the gaps between researchers and staff, here we have typically, there's a little bit of friction between the researchers and the operational staff. The operational folks always have a tight timeline and need to keep things moving. The research folks want to have the perfect study and complete control over the study and the data to make sure every kind of variable is checked off. And this was a quote from a learning health system unit leader. And also some of the example of the risks for non-researchers. Here, this was said by a member of the learning health system unit. We demonstrate the effect of some practice change, outside of our delivery system. And then the problem becomes our delivery system says, oh, but we're different. We're unique. We're not like the rest of the world. And we already know how to do this, and we can do this ourselves, i.e. signaling that the research, just the findings weren't really applicable. They didn't think that the findings would work in their system. They didn't think it was needed. Again, showing divergence between the research and the health system leadership. Next slide. I think this will be my last one before I'll turn it to Michael. So 2 other themes I want to illustrate. One is limited support for implementation and sustainment. So here's a quote by a clinician who was also a learning health system researcher. We had a fellow trying to reduce lab testing overuse. He got really dramatic results. He was funded by a fellow training grant program. He did the initial work under one of these quality improvement training programs. It was a really great effect, but a year later, after he had moved on to other projects, we had started going back again to where we started. I don't think that we helped him either find another leader or embed that improvement really in a practice change. Again, illustrating the gaps between really important findings and sustained in practice changes. And last, the theme of the mismatch between skills and expertise. This was a comment by a learning health system unit leader. To scale up a research-tested primary care team redesign, we needed rapid biostat support and needed to generate regular performance feedback. This is not something that research groups are well equipped to do. We need support staff that has both the skills but also the disposition to want to work in that more kind of rapid, organic, and evolving way. Again, showing different types of research expertise that are really needed. So with that, I'm going to turn it to Michael and see if anything he wants to illustrate in terms of the challenges, and then also let him talk more about the strategies.
Well, let's go on to the next slide. And while we're doing so, I'll just mention that this wanting to have total control over a study is not just an issue of methodology. It's an issue of who's in charge. And remember that this is the researcher versus the senior clinician in terms of struggling for who's going to really call the shots. And that's not always a happy marriage. Fortunately, we've got some optimism on the second part of the presentation, which is my responsibility here. And that is to talk about some of the strategies that we saw actually working to make external funding more useful. As you'll see, some of these are essentially strategies that involve both external and internal funding in a good mix, and others are specific uses of external funding. The first mentioned here is simply that the external funding is used for the test phase and may be used also to spread the research externally as opposed to trying to use it internally. It's good for that, and we have lots of examples of success, including projects that eventually were adopted by hundreds, in some cases even thousands of systems because of their demonstrated impact on clinical outcomes. The second strategy involves aligning the topic and outcome measures in the externally funded study with concerns of top leadership and other system stakeholders. And there's a quote on this that I'll get to in a moment, but this I think is a really important point, namely the outcome measures piece of it. What the CMO is interested in is not necessarily what the chief financial officer is interested in. What the chief financial officer is interested in is not necessarily what the chief executive officer is interested in. Who's your client? One has to ask the researcher if you really want to have interest and engagement in the work that you're doing. It is possible to align those topics, and there's some long-term concerns of systems that, even though the funding may take a year or two to materialize, can be addressed. One thinks of opioids, one thinks of social determinants of health, one thinks of connections with the community. There are a number of these where external funding is feasible and can feed into long-term, enduring system concerns. The other is, of course, to complement external funding with internal funding for implementation and sustainment of valuable practice changes. And we did see some instances of this. Clearly, it was a minority of demonstrated improvements that could be adopted by leadership in this way, but there were cases where this was, in fact, done. The fourth is to create a diversified research portfolio. And this has been referred to in recommendations at various conferences on embedded research in the past. We actually did see it in action in a couple of locations. And there are two variants here. One is that the researchers divide their time. The same individual will do some internally focused and some externally focused work. Or there is a team that's dedicated to the embedded, internally focused learning health system projects, and they call on experts on an as-needed or as-appropriate basis. And that's an interesting way of approaching this. There'll be a quote on that in a moment. Regardless of the approaches adopted, the strategies adopted, it was tremendously helpful for systems and learning health system groups to foster ongoing communication with senior and administrative leadership. This could be quarterly, it could be informal, it could be annual, but researchers needed to know what the senior administrative leadership really wanted and how they were looking at things. And in many cases where there was less success, we found they actually didn't know very much and sometimes learned the hard way. When leadership would come around after a couple of years and say, we just don't get what you guys are doing. The other approach which fostered communication was to actually place LHS researchers onto operational committees and teams. This not only informed them of explicit needs, but it allowed them to be proactive in identifying possible areas for collaboration. And I think more broadly, just to get to understand the mindset of the operational people that they were working with. Next slide, please. So here's some quotes that flesh out these strategies. The first is the one I referred to where the research lead explained how they had gradually become very sensitive to the measures that were relevant to specific stakeholders. We learned to identify the key stakeholders that are going to care about this research project. And what measures do we need to convince those particular stakeholders of the benefits of practices found to be effective? This leader used the term the coin of the realm. Okay, what is exactly the coin of the realm for a particular system leader, whether it's a CFO or a COO, it could be different. The operations officer is interested in an efficiency measure, and the CFO wants to know about the bottom line, as one might imagine. The second quote illustrates internal funding of a project that's initially externally reported. Broad implementation of a new diabetes care path came as a directive from me, says the executive. The individuals were actually already doing funded research based within the Diabetes Institute. We then moved into an operational mode with additional internally funded infrastructure to actually deliver the care mode. And this created a care path that was adopted widely within the system. And the diversified portfolio is illustrated in the third quote. The system's strategic priority 1 year is really to be about suicide risk prevention, and so we can tap our worldwide leader on doing that. And then the next year, there's an interest in a different topic, and we can tap another researcher for that. So this arrangement enables the LHS team to be really nimble and to cover a lot of topics. Next slide, please. So I'm going to give a brief summary of points we've made, and then we have opportunity for what I hope will be rich discussion. And looking at the clock, it's going to allow us about 20 minutes, which is what we had originally planned for. There's no doubt that external funding offers potential contributions to internal system learning and improvement, but it also contains many challenges to the learning health system. The goals and incentives associated with pursuing external funding are radically different than those associated with doing internal system learning and system improvement work. They operate on different timetables. They use different procedures. There are major gaps in the orientations, the subculture, if you will, and in working relations between researchers and other staff. And this is a point which I think Amanda and I, as qualitative researchers with background in social anthropology, really felt very acutely. And it's not something that's been as widely discussed in the literature on learning health systems as I think it really deserves. It's a different mindset to be an operational person, to be doing the everyday work of keeping the system going and making it better, than to be pursuing grants and making presentations and writing papers. It's two different mindsets. And when you've been inducted into that mindset over a period of a decade or more, it's hard to switch gears. So this, I think, is a major challenge. Related to that is that there's often a mismatch between the skills that the research teams have and the skills that are needed for system improvement. One of the interesting gaps here involves quality improvement. Very few researchers have quality improvement skills. Many of them look down their noses at quality improvement as not rigorous. And yet a lot of the actual nuts and bolts work of implementing change requires quality improvement skills to both introduce the change and implement and sustain it. And finally, there's limited system support, limited budget support typically for implementation and sustainment of tested improvements. Next slide, please. I think there are a couple more summary points, but I don't recall, to tell you the honest truth. We'll see in a minute. Yes. Okay. We did find valuable strategies for bridging the gaps. And the first is the diversification of research portfolios using internal funds for learning health system research, implementation, and sustainment, and using the external funding for other purposes, which we've reviewed. Secondly, we found it was very helpful when researchers aligned their topics that they investigated with external funding and the measures that they looked at with system priorities. And third, we found it was extremely valuable to foster communication between learning health system leaders and senior operational leadership, people in the C-suite. And finally, we found it very, very useful when researchers actually sat in operational committees. That could be the safety committee, that could be a human resources committee, it could be a quality improvement committee, it could be in a particular clinical area or overseeing all of clinical work, and got a feel for what it was that really was concerning their colleagues there, and were able to proactively begin to propose ways in which they could conduct studies that might help advance some of the objectives of the members of these committees. Next slide, please. Terrific. We got 20 minutes for discussion, and we want to focus the discussion on how it's possible to conduct learning health system research and also advance science and your careers, because without the latter, the former isn't going to happen. Next slide, please. So let's open it up for discussion. Let's start just with, I think, the first question, which is, what challenges have you faced in conducting research aimed at health system learning and improvement? And more broadly, we can ask, did we capture the challenges? Are there things that we missed that are really important? So let's open it up for discussion. Stephanie, I'm not sure exactly who's going to curate this. How are you going to do it?
I will moderate. Thank you once again, Drs. Borsky and Harrison. We have about 15, 20 minutes for remaining Q&A. And to start, Rabina commented that she could relate to the challenges listed on slide 12 as she experienced a few in at least one of her projects. For her, bringing everyone together to agree on robust methodology was a challenge, likely because it slows down the whole process. Secondly, during the dissemination phase, she found limited interest in co-authoring a journal paper.
I just want to mention in that regard, I recall one researcher who was actually leading a learning health system group complaining bitterly that periodically they wanted to do a controlled study, which was entirely reasonable, but that management would mess things up. Either they would rush to implement broadly, or some other change would occur, which would make it impossible to do any kind of controlled comparison. And very often, management gets committed to a new practice before they have the evidence, and at that point, it's very difficult to convince them to wait and to try to generate rigorous evidence for or against the intervention.
Yeah, Rubina commented that it was an externally funded study and they wanted to move fast, but they had less interest and time to spend on sharing their work with scientific audiences. All right, feel free to put questions in the chat or raise your hand. With our apologies again for our delay with the technical issues. Zoom is a bit finicky today. So
let's add the other question, particularly the second one, which is, how can you balance career concerns with contributions to system improvement? The tension is clear. It's been amply discussed at lots of conferences, and anybody who's done this kind of work has certainly experienced it. How do you balance? What are the tricks of the trade? We have some very experienced folks on the call. I hope some of them will share their sense of what you can do.
Yes, Tim has a question.
Yeah, I think this is all spot on. I think, part of we were talking before everybody joined, we have a training program in learning health systems scholars. And it's really what we're trying to work, you mentioned, I think, Michael, changing gears. And it's really trying to help investigators change gears so that, they can be more ambidextrous, that they understand that their portfolio is chimeric in nature, things that are responsive to the needs of the practice, that would be fed back into the practice. Another stratum in the taxonomy is, something that is important to the practice, but also of interest to the general scientific audience. And then those areas of interest to funders. So I think you kind of have to pivot and move across those strata to be successful. And part of it is, maybe subordinating your own personal research interest to the needs of the practice, but not wholesale. You're not just an empty vessel to be filled by the brilliance of the practice. You have to have, it's almost like switching to, investigator-initiated research where you leverage the relationships you've made with the system. And it's so important to be embedded and establish that trust in a kind of a systems-based participatory model to where, research that you want to lead can be done within that context. And so part of the challenges that we face in doing this work and working with the C-suite and operations is, research is a pejorative. You say it's slow, it's expensive, you have to work with people who overstate the obvious with inaccessible language by design. So it's really trying to, again, through participatory methods, understand the operations side, being on those practice committees, not being, partitioned off in some sort of nerdery. And so being excited and innovated by things that really could be just practice analytics fed back into practice, but also with a little scientific jujitsu that would pass peer review muster. So, what we're trying to train the scholars to do is kind of navigate those different investigative phenotypes. When we say changing gears, it's, not dropping all that you've learned, but, deepening the toolkit so that it's design thinking, use of surrogate endpoints, things that maybe match onto the pace of the practice a little bit better. And that's kind of what a kind of a hallmark of a LHS scholar is someone who can embed, co-create, and work to have some of the research done as a pull from the practice, as opposed to a cudgel exogenous to the practice, convincing them to do this work, and then undertaking an investigation that's so inauthentic and to how the practice is always actually done, so that when it's done, everything kind of reverts back to normal. So there's a mouthful, but I think what we're trying to do in the Scholar program is train investigators to be more anthropologic, give them the tools to answer the right question, and understanding that there are different ways of contribution outside of just the lead author publication and the PI ship on an external grant.
Amanda, do you want to comment on that?
I think just to say, absolutely. I think to your point about being ambidextrous, I think is absolutely spot on. I think, it is different mindsets, it's different goals, it's different languages. And to your point about, needing to be in those committee meetings, that's definitely something I don't think we touched upon here today, but in some of our other papers or other work we've done, we definitely heard that from the interviews that, systems that were more truly learning health system focused, they were part of committees. They had check-ins, or they had different ways of having that interaction between the researcher and the operational leadership, so they could be more connected. They could understand the needs. They could feed information, and potentially start to have more mutual respect for one another. I think it just helped form relationships. So those were a couple of things I think absolutely came up during our interviews. Michael?
So I want to add one thing, which we didn't mention at all, and that is our work was actually done during the pandemic, but our research, but the protocol was developed before the pandemic. So we decided to stick to that and to ask about the status quo, as it were, and then to go back into each system and to ask our chief informant about clear things that had occurred during the course of the pandemic. And when we went back for those half a dozen follow-up interviews, we heard in a number of instances stories of where the pandemic had essentially jump-started that kind of intimate collaboration between the researcher and the operations folks. New committees had been formed that were cutting across a lot of silos, and work had to be done, and it had to be done fast. And the researchers who got involved with that immediately accepted that mindset and did amazing stuff. They did stuff that they said, they introduced, the system spread virtual care in 6 weeks when they had been planning to do it over a period of 4 years, that kind of thing. That was the change in the timetable. And the researchers, were, I think, some of them exhilarated by that, and then subsequently went on to do follow-up studies of the impact of some of the changes that have been implemented very, very rapidly. But there was this ambidextrous quality, this quality of really getting engaged and doing something very different than done before. My sense is it's probably going to be exciting and gratifying for some researchers and frustrating and difficult for others. There's almost a personality element here as to whether you like this kind of uncertainty and enjoy it, or whether you find it frustrating. And some people like playing in the mud and don't mind mud pies being chucked at them periodically, and other people hate it. I think it's partly a personality thing, but also, as Tim has said, it's very much a matter of training, and the new programs are aimed at training for this kind of ambidextrous approach. I just want to mention there's a follow-up slide. Andy, you just want to bring it up for a second so people can see it's there, and then we'll come back to the discussion questions, please. There's a follow-up slide that just gives you both our emails if you want to be in touch, also a paper that's out in healthcare, and another one that's coming out. It's under edit. It's in the hands of the copy editors at the moment. The editorial review has been completed for academic medicine, and there's a lot of parallel between what we presented in that paper. And the final thing on this last slide I just want to mention is a link to an AHRQ site where some of ARC's work is there, including other work that Amanda and I were engaged in. There's a conceptual paper that Steve Shortell and I did, a couple of other papers, and some case studies that a previous ARC director led. So there are other resources there in case you are interested. Andy, can you take us back to the discussion questions now, please?
I have a question kind of bouncing off what was just discussed. So Stuart was wondering, how have you found as qualitative researchers developing teams to address implementation research when many C-suite leaders are interested in quantitative improvements. So how do you balance narratives with operational outcomes?
That's a great question, and my sense is that one possibility is to use existing data, and several of the successful researchers whom we talk with were doing that. In other words, they could move quickly when they could get existing data on a problem or a topic and present that along with some of their suggestions for possible routes for further investigation and or for improvement. That's one possibility, I think, that allows for that. The other is that the storylines are important, I think, also to executives if they're told right. Qualitative research doesn't have to be this sort of lengthy, ponderous, highly nuanced approach that we sometimes see in the journals. It can also be just the nugget, the narrative, the story you can tell in the elevator. It doesn't have to take all that long. And in the same way that Amanda and I, try to capture some of these ethnographic points in just a single quote, those kinds of things can pepper a presentation, I think, with some success as well. Amanda, what do you think about that? I think it's a tough question, and I'm not sure I have a good answer right now.
Yeah, and I just added in the chat, and I'll share, this is from my VHA experience, not from our study, but I have seen leaders really want and need the personal or patient voice, patient stories. And so they still want to know, hey, did this intervention work? Did it move the needle? But to have that voice, to be able, it resonates with a whole different group of folks. So I think having those mixed methods can really help achieve both objectives when possible.
The other thing I'd add, picking up on Amanda's point, is that when you look at the websites of delivery systems, health systems, and also social services, you see a lot of reliance on the quote, a lot of reliance on the individual story, because the communicators know that stuff really is important for reaching a broad audience. So that even if the specific executive may be skeptical of that and may want to know, is this good for the bottom line or not? They also, I think, recognize at some level that they're going to have to give their communications team something a little bit more meat on it if they're going to share this kind of thing publicly. So there may be value there as well.
Rubina shares that early communication and clarity on the scope of the project and the success measures, the publications being one of them, with the whole team are crucial.
Absolutely. Absolutely. There are many clinicians who will value co-publication, but again, you're working not just with clinicians, you're also working with folks who have essentially operational positions. It depends who you're working with and what kind of a project it is. The other thing is, I noticed that in a number of systems where they have research training programs for clinicians, that the focus is not really on publication. The focus is on learning the research methods, doing the project, and moving on. They tend to be short term if they're not really heading in a research in a health services research direction. It's more quality improvement type work that they're doing, and whether there's an external publication at the end or not is not as much of a concern as I would have thought as a originally university-based researcher. It's more, okay, show us the numbers internally and then move on to whatever else you're doing. And these are things that are part of the training, the specialty training. So it depends on who the researcher is and what the researcher's career objectives are.
Tom asks that often he finds that research projects aimed at process improvement wind up being more focused on business organization and practice than on medical concepts. How can clinicians familiarize themselves with this type of research if their background is more in strict medical research or this? And Tim says, apply to our MIN LHS training program. So this will help with that issue.
And I think just to add to that point is, partnerships. So remember, most studies, internally or externally funded have a small team. And so if that's not a skill set that, an individual has, partner with those who do. Again, that can make a broader skill set to include those that, both perspectives are needed.
Yeah, and I will mention on that score that we stimulated some discussion within AHRQ about funding strategies that could actually foster partnership. And in the process, we saw that VA has some solicitations that explicitly call for this. And PCORI has also been struggling with this. And I think you'll probably hear more from ARC in that area as well. Although, as I say, I'm no longer affiliated with ARC. I'm retired. But there is a lot of interest in this. And I think that there's growing recognition on the part of the funders that just having a name on a proposal doesn't ensure real engagement by that individual. One has to look at what the individual is going to do, what % time the individual is going to contribute. And I think genuine dialogue and partnership is going to be increasingly a focal concern for funders like PCORI and VA and hopefully for ARC and NIH as well. And I'm not speaking ex cathedra here as an ARC person anymore, but just as an observation, I think this is a real concern of researchers that they recognize this need for cooperation and collaboration in the whole learning health system area, and will do as much as they can to try to foster it.
Well, I think that is a great note to end on. Thank you so much to Drs. Borsky and Harrison for taking the time to present today. And thank you to everyone for presenting. Again, in closing, please join us for our next seminar on December 5th at noon Central Standard Time, where we will be joined by Dr. Julia Adler-Milstein. This concludes our presentation. See you next time.